Senator Van Hollen.
Thank you, Mr. Chairman. Thank all of you for your testimony today. I appreciate the good comments about Hawaii's innovative systems for addressing some of these issues. As many of you know, Maryland has also developed some innovative models to reduce health spending while improving the quality of care, including the state's all-payer model and what we have now, which is the total cost of care model, a key component of which is the Maryland primary care program. In fact, according to a recent JAMA study, the Maryland primary care program had outcomes when it came to treating Medicare patients in COVID that not only lowered the COVID-19 caseload, reduced hospitalization and death rates, but also found that there was that the office visits did not decrease because of the prospective payment model. So, Mr. Kohler, I know at least in your written testimony you mentioned the Maryland model. Can you elaborate on how more efficient health spending and care delivery results from models like Maryland's? The aim, of course, as I said, to reduce hospital spending and incentivizing high-quality primary care.
Thank you, Senator Van Hollen. And you're absolutely right. Maryland has been an innovator in this area. I think we are very familiar with the Maryland work. We salute it. I think we've actually published some of the findings there. What's important in the Maryland work is, as you know, the idea of putting the entire system on a budget which actually benefits health systems and hospitals because it gives them an assured revenue, much as what we're talking about today for primary care physicians. And then, as you note, the Maryland primary care program. It has been a partnership between CMS and, to Dr. Navate's comments, a large Blue Cross organization, so you have dominant payers. And the results have been really significant. Specifically in that JAMA study that you cited, we also published it, a 20% lower mortality rate during COVID for practices that were enrolled in that primary care program. It is a sterling example of what a combination of hybrid payments, care transformation, and persistence can produce that has saved lives in Maryland, and it's what we're trying to replicate for the entire Medicare beneficiaries.
Well, thank you for those comments, because I do believe that and maybe Hawaii, I'm less familiar with the Hawaii model, but those kind of models can be important. Dr. Novotny, could you just take a moment to pick up on what Mr. Kohler was discussing on how hybrid primary care payment models work to mitigate against the challenges that we find in a solo fee-for-service model, and how the hybrid models can better support whole patient and team-based care?
Thank you, Senator, for the question. So I think, as the Maryland model very nicely exhibits, the hybrid payments with a fixed prospective payment that's going to the practices, it allows them to invest in infrastructure, allows them to staff in a way that reflects what is most efficient to deliver care and meet the patients where they are. So, for example, a telehealth for a patient who wants to do a telehealth visit, or an in-person visit for somebody who wants to do that. It allows them to use technology most efficiently. But one thing I'd also like to highlight right alongside that is it reduces administrative burden, right? Instead of getting these ticky-tack codes where I have to code this and code that, we're actually coding is more costly than the payment you receive. It unshackles them from that system and allows them to invest in ways, as you highlighted, that can really improve preventative care.
Got it. Thank you. Thank you very much. Thank you all for your testimony. Thank you, Mr. Chairman.